fellowship in musculoskeletal. This is part of our fellowship program in musculoskeletal ultrasound. We will be presenting to you a series of topics, and in addition to our full program that's on the website. So this program is delivered to you by the Orthopedic Academy in collaboration with Dr. Kanchan Sharma from the Pain Management Center. And the program is fully accredited by the European Union of Medical Specialties for 40 CME credits. On completion of the program, in total program, you will get a certificate like this one from the European Council for Continuing Medical Education. The program is fully delivered online and it's comprehensive. So we'll cover theoretical knowledge and with a focus on practical patient-based demonstrations. When you log into our program online, you will find that this is the outline of the program that covers all musculoskeletal parts of the body: shoulder, elbow, hand, hip, knee, foot, and ankle. And we will have an interactive academic discussion forum where you will have direct contact with the experienced tutors for questions and for case discussions. So this program is led by Dr. Kanchan Sharma. She's very experienced pain management consultant from India. But in addition to that, she has a wealth of knowledge and experience in delivering ultrasound-related online education. And she has multiple successful programs in this field. So it's our pleasure to be working with Dr. Kanchan, delivering this program to you. As well as Dr. Kanchan, we have Dr. Nicola Evans, who is an orthopedic surgeon. She's trained in Australia and she's currently based in the UK. And she will also, along with me, will help and support Dr. Kanchan in delivering this program. So full details of the full program you'll find on our website, orthopedicacademy.co.uk. And the program is called Fellowship in Musculoskeletal Ultrasound. The first webinar of the series delivered by Dr. Kanchan. She will be talking to us today about the SonoAnatomy of the shoulder joint. And she will look into rotator cuff, the AC joint, and the long head of biceps. And as we explained earlier, we will this lecture is recorded, so please don't worry if you miss any part. You'll be able to access later on, and we'll be in touch with you on how you can access it. We aim to be as inclusive and welcome everyone to take part. So if you have please any questions, please don't hesitate to ask on the chat box area. And we will endeavor to pass on your questions to Dr. Kanchan for full explanation. Please be assured that we fully respect you, and there is no question that's every question we take on its own merit. So please don't hesitate to ask if you have any doubts. Don't leave today if there's anything that's not clear to you. So without further ado, I will hand you over to Dr. Kanchan.
So thank you, Dr. Raz and Dr. Miki. It's always a pleasure to be working with both of you. And I think online education and the webinars, they are the best way of exchanging knowledge. Fine. So today I will be talking about the SonoAnatomy because it's not the pathology and the interventions we are going to talk today, but we will be talking about how exactly we are supposed to scan so that we are on the right track. Fine. I'll start with the SonoAnatomy. But before going into that, I'll just explain you in brief about the anatomy so that when we are looking at the SonoAnatomy, we are very much sure what exactly we are looking at. Fine. I'm working in India right? I'm a certified musculoskeletal ultrasound expert. And whatever pictures I have taken, they are from this 3d4medical.com, and I have got a professional license of that, and I do not have any conflict of interest. Fine. So we will start with the long head of the biceps, right? So when we talk about the long head of biceps, what we need to know about it is it takes its origin from the supraglenoid tubercle, which is somewhere here, along with the superior aspect of this glenoid labrum. Now, what you need to understand about it is, from its origin, when this tendon is moving anteriorly and laterally, right? Something like this. Fine. So here, there should be someone to hold this tendon very correctly, right? So here we have few things to hold it, which are the pulleys, we should say, and about which I'll be explaining you in a while. And after that, this tendon, it just takes an abrupt angulation of 30 to 40 degrees, right? And it is covered by the synovial membrane, which is nothing but a distal extension of the synovial membrane of the glenohumeral joint. Now, why you should know this, that it has got an oblique course? It is because when you are scanning the long head of the biceps in the short axis, then if your beam is not perpendicular to it, you might be ending up in an isotropy. So all these things I will be showing you in a video. But before going into that, you should understand that the movement, how exactly you are supposed to move your probe and why are you supposed to move your probe like that. So we talked about the pulley system, which is gonna hold this biceps tendon at this place, right? So what exactly is that it comprises of? So it comprises of the medial limb of the coracohumeral ligament. Then you have the fibers of the subscap. Along with that, you have the superior glenohumeral ligament. Now, three of them, they will be forming the reflection pulley, and which will be just stabilizing the long head of the biceps there. When you go to the lateral side, you have the lateral limb of the coracohumeral ligament. Along with that, you have the fibers of the supraspinatus. They will be forming the lateral side pulley, and they will be holding the long head of the biceps in place. Now, it is very important because today we are just learning only about the anatomy and the SonoAnatomy. Maybe in our subsequent webinars, when we'll be talking about the pathology, you will understand the importance of learning this, right? Why? Because if there is some problem in any of the structures, you are going to end up in having a long head of biceps, which is just going to go for subluxation or dislocation. And what else you need to remember here is, once this long head of biceps is just moving down, you will just see a change in the shape of the long head of biceps. So initially it will be flattened, just like an oval shaped structure with a large cross-sectional area. But as you are just moving down, it's going to become more rounded with a small cross-sectional area. So here we have learned that it is held there by the stabilizers, the medial and the lateral pulleys. But when it goes inside the bicipital groove, it is held there by the transverse humeral ligament. Now, if you go back to these researchers, they have shown that it is, the fibers of the subscap. Along with that, you have the pec major fibers also supporting the long head of the biceps in the bicipital groove. Once it is coming down from this bicipital groove, right, this tendon is going to become muscle, right? And this will be covered by the tendon of the pec major, right? So beneath the pec major, you will be able to see the myotendinous junction of the biceps, right? So this long head of biceps, this tendon will become muscle, and at the same time, it will be joining the short head to form the belly of the biceps. Fine. And you can see here, this is the long head and this is the short head. Fine. Okay. Then coming to the subscap. So subscap, it's take its origin from this subscapularis fossa. Fine. And it inserts on the lesser tuberosity. But what you need to understand about this subscap is, this subscap has got multiple tendons inside. That's the reason when you are looking at it in the short axis, this subscap is going to have the multipennate appearance, right? And this multiple tendons, they will be combined to form a flat tendon which inserts on the lesser tuberosity. Fine. Now the lower 1/3 has got a membranous slip that directly inserts on the lower aspect of the lesser tuberosity and the anterior aspect of the diaphysis of the humerus. Now, about this subscapularis, you need to understand one thing, that it's upper tendon, okay? This one. So what it does, it just sends a slip which extends to this bicipital groove. Why? So that when your long head of biceps is coming down, it will be able to slope gently over it, right? And that's the reason when you are looking for the upper fibers of the subscap, you need to just scan till you're able to see the long head of the biceps very nicely. Fine? Okay. So this is how exactly your subscap will be. Now, what you need to understand here is when you are looking at the long axis of the long head of the biceps, if you are going to move your probe, it is the short axis of the subscap. So always remember they have got a T configuration, okay? Long head of biceps, if you're going to move your probe, if you have seen the longitudinal axis of the long head of biceps, and if you're going to move the probe exactly like that, then you are going to see the short axis of subscap. But when you are looking at the short axis of the subscap, and if you are going to move your probe towards the medial side, you are looking at the long axis of the subscapularis. Very, very important. Then coming to this humerus, okay, the footprints of all the rotator cuff tendons. For rotator cuff tendons, earlier what we have thought that this greater tuberosity has got three facets, okay, superior, middle, and the inferior facet. And supraspinatus will come here, infraspinatus will come here, and teres minor will come here. And the mnemonic to remember it was SIT, as superior was for supraspinatus, middle was for infraspinatus, and the inferior was for teres minor, right? But that is not the scenario now, which we will be learning in the next slide. But before going into that, you understand this picture very nicely so that in the ultrasound, when we are just moving the probe, you will understand what exactly we are looking at, right? So when you look at this, facet, that is the superior facet. You see, the superior facet is something like this, okay? But when you are going to the middle facet, it is something like this, right? So if I am going to move my probe and if I am going to see something like this V, it means I am looking at the junction where my superior facet is meeting up my inferior facet. So when you are looking at the superior facet, I always say that remember that, the junction with the head and the greater tuberosity, it is something like this, okay? And letter 3, which I have drawn it like this, that's all, fine. But when you are going to the middle facet, so this was the superior facet, something here, okay, and then something like this. But when you are going to the middle facet, you will see it's flat, right? So this will become like a spoon, something rounded and then flat. So when you are over the middle facet and you are just scanning, so it will be something like this. Fine. So number 3 is for the greater facet and for the superior facet, and for the middle facet we have spoon, okay, which you have just kept it upside down, right? So that is how your middle facet will be looking like under ultrasound. So what has changed regarding what I have spoken in the last slide? Now, the cadaveric studies, they have shown that the supraspinatus, okay, it just have a triangular insertion, and the posterior lateral aspect is covered by the infraspinatus. So infraspinatus has got a trapezoid footprint, and when it goes to the supraspinatus, so the supraspinatus has got a triangular footprint, okay? And many studies, they have shown even the supraspinatus coming up to the lesser tuberosity also. Then when it comes to supraspinatus, so supraspinatus has got anterior bundle and a posterior bundle. And now they have just classified, in fact, the anterior also into subcategories. So in the anterior bundle, you will see that this has got a bipinnate appearance with a very long tendon, right? Bipinnate means the muscles, fascicles, they will be coming towards one tendon. But when you go to the posterior bundle, it has got a strap-like configuration, okay? And this posterior bundle, the tendon is very small. So if you're looking something near the biceps, okay, so here, this is the bicipital groove, right? Something near the biceps is going to be the anterior bundle of the supraspinatus. Fine? Okay. Now, when you want to see the supraspinatus, right? So what happens? You have this acromion, right? Which will be just casting an acoustic shadow. So you cannot see it in the neutral position. That's the reason we have certain positions to visualize the supraspinatus with ultrasound. I'll be teaching you one very nice technique. I usually prefer that technique rather than what is given in the books, and you will be able to see the same picture, right? So that we'll be seeing in our video. Then we usually identify the supraspinatus from the posterior aspect also, because it's take its origin from the supraspinatus fossa. Posteriorly also, you cannot visualize it fully here because you have the acromion that will be casting the acoustic shadow and it will not be letting you examine this. Fine? Okay. And this is what I was telling you, that the posterior lateral aspect of the supraspinatus will be covered by infraspinatus, and that is how it looks like under ultrasound. Fine? Okay. When it comes to the infraspinatus, so infraspinatus has got two heads. One is the oblique one, another one is the transverse one. Now this transverse one, as you can see, it's take its origin from the inferior surface of the spine of the scapula, and it just travels, laterally. But your oblique head or part, it is just a fan shape, right? And it is the one which will be traveling superior laterally. And then both of them, they will be combining here, and the lateral part we have already learned. Fine. Coming to this infraspinatus, when you are seeing it, just remember a protocol that when you need to palpate the spine, which is nicely palpable, if you're not able to palpate, you can just put the probe, and if your probe is over the bone, you won't be able to see anything beneath it, right? Because of the bone cast in posterior acoustic shadowing. So you won't be able to see anything. Whatever comes, it will be reflected back to the transducer. Fine. So what happens if from the spine, if you're going to go up, you will be into the supraspinatus fossa. So you will be visualizing the supraspinatus. But once you are coming down from the spine, you are in the infraspinatus fossa, where you will be visualizing the infraspinatus. Now, a very important thing which you should understand is when you are scanning the infraspinatus, don't keep your probe just transverse, okay? You need to go a little more oblique, right, from this spine, because how your spine is oriented like this. But what most of us, we usually do is we move our probe in this direction only. No, you are supposed to move your probe in an oblique manner here, right? Not exactly, I should say, parallel to the spine, but yes, little oblique. Then only you will be able to follow your infraspinatus very nicely. And once you are moving over the infraspinatus, right, you will be able to appreciate the spinoglenoid notch, which will be harboring your suprascapular nerve, right? And of course, you will be able to see the joint very nicely. Fine. So when you are scanning the infraspinatus, we usually see the infraspinatus, we usually see the spinoglenoid notch, and then we go for the posterior glenohumeral joint also, because everything you will be able to visualize once you are moving your probe. Then comes the teres minor muscle. So teres minor muscle, it's take its origin from the superior aspect of the lateral border and the adjacent area, and it inserts itself on the inferior facet. Fine. Now, I have a very nice technique of identifying the teres minor. What usually I do is, if this is the posterior, I should say here, okay. So this is the posterior axillary fold. Just 2 fingers from there, you keep your probe in a craniocaudal direction. Then you will be able to appreciate this teres minor in the short axis, right? And then you can rotate your probe, look for it in the long axis and follow it up to its insertion. This is very easy. Okay, within fraction of seconds, you will be able to identify the teres minor, because it is very important to look for the teres minor, how exactly it looks like under ultrasound. Why? Because when you are expecting any kind of axillary neuropathy, we usually look for how exactly the teres minor is looking like to you, right? Otherwise, when it comes to the rotator cuff, tendinopathies, teres minor is least affected, right? So importance of learning teres minor is to rule out the axillary neuropathies. Then we'll be going to the acromioclavicular. It is always on the top portion of the shoulder, right? So what you are supposed to do, you are just supposed to look for it at the top of the shoulder joint. Once we have seen the capsule, and the capsule condensation is the superior acromioclavicular ligament, then we have the synovial membrane, and then we have a fibrocartilaginous disc. Fine. So when you want to scan the long head of biceps, right? Now look at this volunteer. Now what you need to remember here is this arm should be by the side of the body. Elbow is flexed, okay? Forearm is supinated and palm facing up. So always make a routine when you are scanning that you just give a pillow so that they are having an additional support, right? Whenever you are scanning the long head of biceps. So you palpate the acromion, which is here, right? Which I'm showing you. And then you keep your probe approximately 6 fingers down, okay? In short axis with the aspect marker towards the lateral side. Now here what you need to remember is that you don't have to look for anything, okay? Just look for the shaft of the humerus, which will be appearing like an inverted U-shaped structure, something like this, right? And what should be your motto is to follow this inverted U so that it duplicates itself. Means you have to keep moving your probe up until this inverted U will become 2U. And believe me, 99% of the time you are there at the bicipital groove. But what all you have to follow, that you understand that this long head of the biceps has got an oblique course. So once you are moving your probe, you need to move your probe towards the ipsilateral ear lobule. Make this as your target, that you have to move your probe towards the ipsilateral ear lobule, right? And we'll be seeing that now. Acromion, 6 fingers down, probe in short axis with the aspect marker towards the lateral side. We have looked for 1U, and now I'm just moving my probe. Once I'm moving my probe, what has happened? The U has become 2U. 1U is this and another U is this, right? Because my aspect marker was here, it shows this is the lateral side, this is the medial side. So lateral side and the medial side. So if that is the lateral side, it has to be the greater tuberosity, nothing else, right? And it has to be the lesser tuberosity, nothing else. And this is going to be your bicipital groove. You have the long head of the biceps, which is here, and one arterial pulsation, which you are able to see, that is by the anterior humeral circumflex artery, right? And this fibrillar structure, which you are able to see on the top, that is the transverse humeral ligament, and this muscle is the deltoid, right? So how easy it was? We have to just look for a U, and we have to just make this U becoming 2U. So we'll watch it once again. We have kept our probe. We are just moving. So initially we saw only 1U, and we are just moving our probe without thinking what we have to do. I have just slided the probe medially so that long head of biceps is in the center. Supposedly you are not able to see the hyperechoic cluster dot-like appearance, but you are able to see something like this, right? Do not label it as tenosynovitis, right? Before labeling as tenosynovitis, it could be because of anisotropy. So what you need to do, you need to just toggle your probe so that your beam is aligned to that structure, and then that structure, that blackishness, anechoicness will go off and it will become hyperechoic. Means this anechoic thing was because of the problem with your probe, right? Not because of any pathology. But supposedly you have just toggled your probe also, and after that also you are not able to see the hyperechoic cluster dot-like appearance there, then it is pathological. So any tendon, when you are evaluating, please make sure that you are eliminating the anisotropy. Tendons exhibit maximum, followed by your ligaments, then you have your muscle, and the least, or some book even says that no anisotropy, okay, that is nerves. Fine? Okay. So once you have identified in the short axis, right, you can rotate your probe, and you can look for it in the longitudinal axis. So in the longitudinal axis, you will be able to see the hyperechoic fibrillar pattern, right? And I'll teach you one more technique. Supposedly you are not able to, see with this technique where you are supposed to identify the long head of the biceps in short axis and then just rotate your probe, right, to 90 degrees and you will be able to see. But supposedly you are not able to see in any obese individual. What is the, rescue maneuver which you should do? Is you identify the lesser tuberosity. And I always say for any particular joint when I'm scanning, I always say that this is my home page view. So when it comes to shoulder, my home page view is when my probe is in short axis, okay, with the aspect marker towards the lateral side, and I'm over the bicipital groove where I'm seeing the greater tuberosity, lesser tuberosity, and the long head of biceps in short axis. So I call this, view as my home page view. And if I'm lost, I will come back to this view only. So what you need to do here is you put your probe with the home page view, and then you identify the lesser tuberosity, which I'll be showing you, and then you rotate your probe, right? So lesser tuberosity fully, it's a bone, so you will be able to identify it very nicely. And then you slide your probe laterally and you will be able to see the long head of the biceps in longitudinal axis very nicely. Like this, you put your probe, identify the lesser tuberosity, rotate your probe to 90 degree, identify the lesser tuberosity, and then slide your probe laterally so that you are able to see the long head of the biceps nicely. Okay, so I'm showing you that now. So we have come to the home page view. Now I have just moved it towards the lateral tuberosity. I have rotated it to 90 degrees, and what hyperechoic line casting an acoustic shadow, which you are able to see, that is the lesser tuberosity. Fine. And see, I'm sliding my probe and there I am able to see the long head of the biceps very nicely in the longitudinal axis. Now, to evaluate the biceps, if you go back to the home page view, you will see here that once you are in the bicipital groove, it is like a rounded thing. Okay. So what I'm doing from here, I'm just moving my probe up. And once you are moving towards its intra-articular portion, this rounded portion will now become oval. Okay. So that is what we will be seeing now. So from the home page view, now I'm moving up. I'm moving up. Okay. If I'll go more up, I will be able to see everything very nicely. Okay. So see, that is the pulley system. Okay. Which is holding this long head of biceps, see, very nicely. So at the bicipital groove, this biceps was lying very close to the bone, right? But as it is going towards the head, right, you can see that there is something which is lifting it up, right, which is supporting it very nicely. So you can just correlate it with this diagram, right? Okay. So now we'll be seeing the myotendinous junction, both in the short and the long axis. To look for the myotendinous junction, again, we'll go back to the home page view. And from there, we are going to slide our probe towards the elbow joint. Once we are sliding our probe towards the elbow joint, we will be able to see the pec major tendon, which will be lying over the long head of biceps. Once you are seeing the pec major tendon, do remember that you are supposed to put the shoulder into external rotation so that you are stretching the pec major tendon and you will be able to see the tendon fibers nicely. And if you are going to follow it little more, you will be able to see the muscle belly of the long head of biceps. This is what we will be seeing now. So just see, we are in the home page view, right? From there, I'm sliding my probe down. I'm just sliding my probe down. And then I could see the fibers of the pec major, okay, which are just coming on the top. And at this moment, I will be asking my volunteer to put his shoulder into external rotation, and you can beautifully see now the fibers. And if I'm going to slide more down, you will be able to see the muscle belly, which is this structure, right? And then this will be combining with the short head to form the biceps brachii muscle. So again, to see it in the longitudinal axis, we will see it in the short axis. We will rotate our probe. And the same thing, now we will be just moving our probe towards the elbow joint. And if you are not able to see it nicely, you can toggle your probe, you can use the heel toe maneuver to identify the fibers and keep moving down. Once you are moving down, you will be able to see that this tendon has become muscle. Okay, so that is the myotendinous junction. Now we'll be looking for the dynamic evaluation of the long head of the biceps. For that, we need to put the shoulder into external and internal rotation. And when we are doing that, we should always see that the long head of the bicep should always remain within the bicipital groove, right? If it is just going out and it is coming back, that is subluxation. So let's see that. So we'll go back to the home page view. We will identify the long head of the biceps in short axis. Okay. And now I'll be asking him to put his shoulder into external rotation. Once he is doing into external rotation, we will just make sure that we are able to see the biceps nicely, and then again into the internal rotation. So it is always remaining within the bicipital groove. It is not going out of the groove, right? So there is no subluxation. Then we will be looking for the subscap. So to examine the subscap, it is the external rotation which you should go for. So again, you put your probe at the short axis, okay, identify the home page, slide your probe medially, okay. And once you are sliding your probe medially, what you need to do here is obviously the external rotation, right? So once you have done the external rotation, I will tell you one thing, that this probe, once we have done the external rotation, you need to tilt the medial side of the probe in such a manner that your subscap is pointing towards 10 o'clock when you are scanning the right shoulder, and it should be pointing towards 2 o'clock when you are scanning the left shoulder. That is the best way to look for the footprint of the subscap. And you need not stop here, because you need to keep on scanning it fully until you are able to see the long head of the biceps in the short axis. And this is what we will be seeing now. So we'll be moving our probe up, okay, from this position, because you are able to see the footprint of the subscapularis, and then we are going to move our probe up. So how long you should be moving? Until you are able to see the long head of the biceps nicely, because we have seen the superior tendon will be just sending a tendinous slip. So we should be evaluating whole of the subscapularis. So that is what was the long head of biceps in short axis, right? And when you are evaluating the long head of the biceps, once you have reached there, you reduce the external rotation little bit so that you will be able to evaluate it nicely. This is what I have done. And then again, once your probe is in the longitudinal axis of the subscap, you can just rotate it to 90 degrees, which I'll be doing now. Okay. And then you will be able to look for the short axis of the subscapularis. Now, the subscapularis in the short axis has got a multi-pennate appearance. Okay. These hypoechoic things which you are able to see, they are the muscle fascicles. So don't think they are the tear and just write in your report as the tear. Second thing is another technique of identifying the subscapularis in the short axis. You identify the home page view, slide your probe little more up so that you look for the coracoid process in the short axis. Then rotate your probe and make it a long axis, okay? And then tilt the footprint of your probe towards the lateral side, right? So what you are seeing now is the coracoid process in the longitudinal axis. Now I have tilted the footprint and I'm able to see the all these rescue maneuvers will be really helping you a lot when you have to scan any kind of obese individual. You are not able to find, there is so much of fat there, right? Acromioclavicular, we have already seen it is on the top. So you have to just keep your probe on the top, okay, of the shoulder joint with the aspect marker towards the lateral side. And then you will be able to see something like this. So this was the lateral side, this was the medial side. So this is clavicle, this is acromion, and that is the acromioclavicular ligament, and that is the joint space. So this is the easiest joint to identify with ultrasound. And then we have the supraspinatus. So this is the modified Kras position. Okay, your shoulder is into extension. Okay, elbow is flexed and the palmar aspect of the hand is resting on the ipsilateral hip. So in this position, the supraspinatal will be coming out just beneath the acromion. So you will be able to evaluate the tendinous portion of the supraspinatus nicely. So I will teach you one simple tip from my practices. You know what happens when you are learning ultrasound for the first time? You're confused how to look for the longitudinal axis, how to look for the short axis. So do remember that if this is your clavicle, right, and your probe is parallel to it, something like this, you are looking at the short axis of the supraspinatus. If this is your clavicle and your probe is like this, fine, you are looking at the longitudinal axis of the supraspinatus. So T has got lots of tips when you are scanning the long head of biceps, subscap, when you are scanning the supraspinatus, the longitudinal axis and the short axis. Fine. So this is what I was just trying to show you from this video. So that is the clavicle. Now this is the longitudinal axis. Fine. Okay. And that is the short axis if your probe is like that. So now what you can do in order to identify the supraspinatus. So there is one tip again from my side. Okay. So what you can do is you palpate the deltopectoral groove. 2 fingers from there, you keep your probe, okay, with the aspect marker towards the lateral side. You identify the long head of biceps, okay, and then keep on moving up until you are able to see the number 3, right? So I will just freeze it here. Okay, I just moved. So this is what I was talking about, okay? You are able to evaluate the supraspinatus nicely. You're able to see all the fibers very nicely. So if this is your deltopectoral groove, 2 fingers from there, you put your probe with the aspect marker towards the lateral side. That's the medial side and this is the lateral side. Just 2 fingers from there, you put your probe and then you keep on moving up until you see what I have taught you, right? Exactly 99% of the time, you will be absolutely right, right? So once you are there, okay, and if you are going to go, little more posterior, you will see what I have taught you. It will become like a spoon, right? So what you are seeing here is the crisscrossing of the fibers. Your infraspinatus is going like that, your supraspinatus is coming, so you have reached basically the middle facet, right? So that's the reason it should never be flat. If you are evaluating the supraspinatus, it should always be elevated, right, like an inverted V. And once you have evaluated it in the longitudinal axis, and then you can just rotate your probe and you can look for the supraspinatus in the short axis. If you will slide your probe towards the ipsilateral nipple, you will be able to see the long head of biceps. And in the short axis, if you will go posterior, you will be able to see the infraspinatus, which will be covering the supraspinatus from the posterior aspect. Now, in the alternate position, what I do is usually the position which you have used to look for the long head of the biceps, keep it in the same position. What usually I do is I keep my probe in the home page position, then I slide my probe towards the greater tuberosity. Once I'm over the greater tuberosity, I just slide my probe up until this greater tuberosity will fall and I will just reach to the head, right? And at that moment, I will be putting just a little bit of extension of the shoulder joint and you will be able to see everything very beautifully. So this will be the position and then I'll be just putting the shoulder into extension. That's all, okay? How much they can do, that will be fine. So here is the home page position. Now I'll be shifting my probe towards the greater tuberosity, right? So that is a greater tuberosity. I'll keep on going up, up, up until this greater tuberosity will fall. I'll put the hand into a little bit of extension and I'm able to see the supraspinatus in the short axis, the way I have seen with the standard techniques, right? And then I'm going to follow it up until I see the coracoacromial ligament, and then I'm following it down until I see that V which I have taught you, right? So you need to follow it down till its insertion, right? Because the tendinopathies will not take place at the head. They are taking place towards the insertion. So you need to evaluate the supraspinatus nicely. And then if you want to look for the longitudinal axis in this position, you just rotate your probe to 90 degrees and you will be able to see it nicely. So that is how basically you evaluate the supraspinatus. You can ask the patient when you are scanning the posterior aspect to keep the palmar aspect on the opposite shoulder or on the opposite knee, right? Whatsoever it's comfortable for you. And once you are going to the posterior aspect, very important is your finger probe, right? I always say to my students that palpate the bone. It really helps you a lot in learning ultrasound in your initial days. So what you can do is you palpate the spine, right? So once you're palpating the spine, you know above that is the supraspinatus fossa. You should be looking for the supraspinatus, and beneath that you're going to have your infraspinatus fossa, where you will be looking for the infraspinatus. Now, when you palpate the acromion, okay, you will see that your finger will dip at a point just beneath it. I'm showing you that, right? So that is the point exactly for the posterior glenohumeral joint. If you'll keep your probe exactly there, 99% of the time you are looking at the posterior glenohumeral joint very nicely, okay? So first we will be evaluating the supraspinatus. I have kept my probe over the spine of the scapula. I have slided anteriorly and I'm able to visualize the supraspinatus, which is this muscle, and on the top we are having the trapezius, right? So then what I am going to do is I will be following it, okay, and I will be able to see the central tendon very nicely, which is here. And if I move more laterally, I was able to see the acromion. I'll come back, evaluate it nicely in the longitudinal axis, and then I'll be rotating my probe, okay, and I will be evaluating it in the short axis as well. Because when you want to look for any kind of atrophy, it is the short axis which is preferable, not the long axis. Then in the infraspinatus, we'll just palpate the spine. We'll keep our probe beneath it and we'll keep on moving our probe towards the lateral side. Here you will be able to see the deltoid, the infraspinatus, which is here. This is the glenoid, that is the labrum. This is the head, that is the cartilage. Then you can follow it laterally. You will be able to see its insertion there. Fine. Then rotate it and just look for it in the short axis. Do remember the size of the infraspinatus is twice the size of the teres minor. To look for the teres minor, what I have taught you, 2 fingers from the posterior axillary fold, you keep your probe in a craniocaudal direction. You will be able to identify the teres minor, which is this. So this is the teres minor, which will come if I'll slide my probe up, right? This is your axillary nerve. This is your posterior circumflex artery. So how it will be, if you will slide your probe up, you will be able to see the head. So it is like a person who is sleeping on the sling, okay? So a question mark, usually when we go for a vacation, we usually lie down in a sling. So remember it, it is the question mark, and question mark is you have the head and then the shaft and you have the teres minor lying there, right? And if you can just rotate your probe to 90 degrees, you will be able to see the teres minor in the longitudinal axis, and then you can follow it up to its insertion. So that's all in the scanning part. Now, if you have any doubts, you can ask me. Anything you would like to ask in the scanning, you would like to understand, you would like to see again.
Dr. Kanchan, that was wonderful demonstration of the normal anatomy and how to perform diagnostic sonography of the shoulder. I liked how you demonstrated how the position of the probe and then what structure it shows and how the structure appears according to the position of the probe. It makes a lot of sense when you see both in one slide.
Yeah, it's good if you want to recall the anatomy, it's always better to see that. Yes.
Yeah.
So thank you for that. Any questions from anybody? Anyone? So briefly, I'll tell you a few things. When you want to scan the long head of biceps, go with the U and then the duplication of U, right? When you are scanning the supraspinatus, right, follow the alternative position. Very easy. Go to the home page, slide your probe towards the greater tuberosity, go up, you will be able to see the supraspinatus in the short axis. Rotate your probe. When you are looking for it in the longitudinal axis, look for the figure of 3, right? And when you're looking for the infraspinatus from the anterior aspect and going to the posterior, it should always be a spoon which has just, you have just kept it upside down, right? Third thing, teres minor, follow this 2 fingers technique. Believe me, within fraction of seconds, you will be able to see. And if you want to see for the posterior glenohumeral joint, you just palpate the acromion, the lateral border. Beneath that, you will be able to see one dip, right? That is exactly where your joint is. So if you are moving from the infraspinatus, you are lost. You are just moving your probe in a wrong direction and you are not able to see the glenohumeral joint nicely. You follow this technique, it will really be helping you in your day-to-day practice, right? So if anyone has got any question, you can ask me or we will play some Kahoot. Let's see how much you have gained. Okay. How effective I was in delivering the lecture. I should say like that. So there'll be one QR code which will be coming on your screen. You can just scan the QR code. Okay. I'm sharing the screen. You can write whatever name you want to write for yourself, X, Y, Z, because nobody is going to see your marks or anything. Or you can just visit kahoot.it, www.kahoot.it, and you can just enter this pin which is getting displayed on the screen. I'm writing the pin there, okay, in the chat box also, so that if you are logged out in case of anything, any problem, you can just log in again. And the recordings will be available. So in case you want to watch it again, so you can really see it again and again. Oh, somebody has kept the name as Long Biceps. That's really nice. That's all. Nobody else wants to join? Dr. Firas, can we play with 3 participants? Is it fine?
Yeah, of course. Yeah.
Okay. Okay, if supposedly you change up your mind and you want to play, so please go to www.kahoot.it, enter the pin, and you will be inside the game. Okay?
Come on,
So,
guys, everyone joins. It's interesting. It reinforces what you learned and completely anonymous. You could put any name you like, and no, we will not be able to trace you. So don't
yeah,
not to
and
worry.
we don't want also. You can write anything, whatever you want. You can write biceps, supraspinatus, subscapularis, acromion, greater tuberosity, lesser tuberosity.
Yeah, it's a good game. Let's all join, guys. And the most important, it reinforces. That's how you reinforce what you learned. Um, so multifaceted. So by discussing, by thinking about the answers, you will remember the facts much better.
Okay, I'm starting up. Good luck to everyone. So here goes your first question. Long head of the biceps originates from infraglenoid tubercle, supraglenoid tubercle, bicipital groove, coracoid process. You can just press on the color coded bars, not on the screen. You should have it in the other app, means other, I should say mobile or PC. Just click on the color coded bars. Okay. So most of you have answered it correctly. It is supraglenoid tubercle. Fine. Second question, infraspinatus tendon inserts on superior facet of greater tuberosity, middle facet of greater tuberosity, inferior facet of greater tuberosity, both superior and inferior. Okay, so it inserts on both superior and inferior. That's why it has got a trapezoid footprint. So third question, true about supraspinatus tendon. Superficial fibers are convex, deep fibers are parallel, lies below the acromion process, nicely identified in neutral position. So this is out of syllabus. Let's see. But I have taught you this. Okay. So superficial fibers, they are just talking about the posterior one, right? So they are basically parallel. And when you go to your deep fibers, or you can say your anterior bundle, it has got, the fibers, they are convex. Fine. So it is just the opposite. And of course, it lies below the acromion process and you cannot identify it in the neutral position. That's the reason we have the modified cross position to visualize the supraspinatus tendon. Okay, your fourth question. Normal labrum appears hyperechoic, hypoechoic, anechoic, isoechoic. Okay, so whenever we are talking about labrum, it's a fibrocartilaginous structure. And fibrocartilaginous structures are hyperechoic under ultrasound. And when we are talking about the hyaline cartilage, that is homogeneously hypoechoic. Okay, that is how we differentiate between these two cartilages. Fifth question. Subscapularis has the following appearance under ultrasound: bipinnate, tripinnate, multipinnate, rectangular. So it has got a multipinnate appearance under ultrasound because multiple tendons are there within the subscap. Sixth question. Rotator cuff interval comprises of all except subscapularis, short head of biceps, supraspinatus, coracohumeral ligament. Okay, so what basically we learn about the pulley system, that was exactly the rotator cuff interval. On one side, you had the subscap. On the other side, you have the supraspinatus, right? Then we have seen the coracohumeral ligament, right? Coracohumeral ligament. Then we have seen the SGHL, right? And it has got capsule also. So everything, it just comprises in the long head of biceps. So everything comprises of the rotator cuff interval. Short head of biceps will not come here. So seventh question. True about acromioclavicular joint is all except lies on the top of shoulder. Trapezoid ligament connects the clavicle and acromion. Superior acromioclavicular ligament lies on its superior aspect. It contains a fibrocartilaginous disc. Okay. So trapezoid ligament connects the clavicle and the acromion. That is wrong because what is trapezoid and the coronoid ligaments? They are the part of the coracoclavicular ligament. And whenever we talk about the ligament, it is always between two bones. So you have the coracoid process on one side and then you have the clavicle and we have the trapezoid and the coronoid ligament. So that was wrong. What happened? So I will share it again. I think it got stuck. Okay. So pectoralis major tendon covering the long head of biceps is best examined in adduction, abduction, external rotation, internal rotation. So here I'll tell you one tip, okay, and which will be helpful if you want to examine any tendon inside your body, right? Always remember, whenever you want to examine any tendon under ultrasound, you need to stretch the tendon. How can you do that? By just doing the action which is just opposite to the tendon. For example, PAC is an adductor, right? So what we have to do? We have to do an internal rotator. So we have to do the, I should say, the external rotation because we need to stretch it in that manner, right? This abduction also you can examine, but this is the best which is given in the book, that you need to go for an external rotation. So you will be stretching the fibers. Same thing with the subscapularis. It's an internal rotator. So when you are examining the subscap, you need to go for an external rotation. So what you are doing, you are stretching it, right? Then ninth question, axillary nerve lies beneath the following, beneath the short axis of the following muscle. Okay, the following is wrong there. Teres major, teres minor, infraspinatus, supraspinatus. So axillary nerve lying beneath which muscle? Short axis of which muscle? So that is teres minor. Then our last question. Long head of biceps in the bicipital groove is accompanied by posterior circumflex artery, ascending branch of the anterior circumflex artery, descending branch of the anterior circumflex artery, anterior circumflex artery. So usually when we talk about the vascular supply of the long head of biceps, it has got three zones, right? One which is near the origin. So that is supplied by the branches of the thoracoacromial artery. The lower portion, when it is near the PAC major, right? It is supplied by the branches from the brachial artery. And the mid portion is supplied by your anterior circumflex artery, the branches of the anterior circumflex artery. So let's see who is on the podium and let's play some music for that person. So third position, we have long head of biceps. Second is Shaida. First position. Okay. Runners up is Senik, Athena. Okay, congratulations. So I hope all of you enjoyed today's session. And if you have any doubts still you want to ask, you can ask, or you can just write in our discussion forum, which is there on the Orthopedic Academy website. We'll be sharing the recordings. So you can just contact us if you really want to watch the recording, right? So we'll be sharing you how, we'll be actually sharing you where exactly we will be just putting up our recording. So anything else, Dr. Firaz?
Thank you very much, Dr. Kanchan. That's fantastic. You kept us all engaged to the end. It's a very difficult task to do, and maybe we should next time offer a prize for the whoever wins.
Yes.
Something. It was very interesting, actually.
So we will offer them our book, okay, after they have played all the webinars. So at the end of December, who will be the winner of that will be getting.
Yeah, I think that's a very good idea. Whoever
Yeah.
scores more, we will look at that.
Okay.
Do you have any questions, Nikki, or comments you would like, or
Okay, somebody is asking for a feedback link. Yes, we will share.
Yeah. Yeah.
You
We
can
will
share your feedback. That will be helping us to improve ourselves.
Yeah.
Yes, Nikki, do you want to say something?
No, I was just going to ask about the feedback link for the people that were asking.
Yeah.
I
Yeah.
have the email ID, those who have
Yeah.
registered, so we can send them a link.
Yeah.
Perfect. Perfect. Yeah, it was really entertaining. Thank you.
Yes.
Great. Excellent. Well, thank you very much, Dr. Kanchan.
Thank you, Dr.
Thank
Firaz, and
you.
thank you everyone for joining us for this session. Hope we'll be meeting up very frequent in future, and we will be updating our knowledge, okay, by exchanging ideas. So thank you. Good night. Bye-bye.
Guys, you go to Orthopedic Academy website for to subscribe to the next webinar.
Yes.
See.
Okay. Bye-bye, everyone. Good night. Take care.
Bye-bye.